بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Again, I'm Dr. Fatma elwakeel, and I would like to talk about tricuspid valve disease. Tricuspid regurgitation. Trivial tricuspid regurg is frequently detected by echocardiography in normal subjects. Pathological tricuspid regurg is more often secondary due to right ventricular dysfunction following pressure or volume overload in the presence of structurally normal leaflets. Primary tricuspid regurg may be due to infective endocarditis, rheumatic heart disease, carcinoid syndrome, myxomatous disease, endomyocardial fibrosis, Epstein's anomaly, drug-induced valve disease, thoracic trauma, and iatrogenic valve damage. Tricuspid regurg lead to right ventricular and right atrial dilatation, leading to increased annular diameter, which further increases the severity of tricuspid regurg. Severe tricuspid regurg can also induce ventricular interdependency and leading to reduction in both right-sided stroke volume and left ventricular preloads. Hemodynamic abnormalities increase during inspiration. Evaluation of tricuspid regurg. First, from the history. Even severe tricuspid regurg may be well tolerated for a long period of time. It is most often discovered during an echocardiographic examination for another cause. Predominant symptoms are those of associated diseases. Dyspnea and fatigue are common. Anorexia and weight loss may occur at a later stage. On physical examination, there may be a soft holosystolic murmur best heard along the left sternal border and in the xiphoid region, and increases with inspiration, together with systolic jugular venous expansion and a pulsatile and enlarged liver with hepatojugular reflux. The ECG usually shows AF and incomplete right bundle branch block. Chest X-ray, usually there is marked cardiomegaly due to dilated right side. Echocardiography is the ideal technique to evaluate tricuspid regurg. The presence of structural abnormalities of the valve differentiates between primary and secondary tricuspid regurg. The etiology can usually be identified from specific abnormalities. Example, vegetations in cases of infective endocarditis, the presence of leaflet thickening and retraction in rheumatic and carcinoid disease, prolapsing flail leaflet in myxomatous or post-traumatic disease, and dysplastic tricuspid valve in congenital diseases such as Epstein's anomaly. In secondary tricuspid regurg, the degree of dilatation of the annulus, the right ventricular dimensions and function, and the degree of tricuspid valve deformation should be measured. Significant tricuspid annular dilatation is defined by a diastolic diameter of at least 40 mm or at least 21 mm per meter square in the four-chamber transthoracic view. In secondary tricuspid regurg, a coaptation distance more than 8 mm characterizes patients with significant tethering. Evaluation of tricuspid regurg severity. Cardiac flow mapping, color flow mapping of the regurgitant jet usually lacks discrimination between mild and moderate regurgitations. The systolic flow reversal in the hepatic veins identifies severe tricuspid regurg, but also lacks sensitivity for less severe regurgitations. The width of vena contracta seems to be the most reliable quantitative index. Vena contracta diameter more than 7 mm is a good marker of severe tricuspid regurg. The proximal flow convergence method has been validated in only one study. Criteria for severe tricuspid regurg where an effective regurgitant orifice area more than 40 millimeter and a regurgitant volume more than 45 millimeter milliliter. Evaluation of right ventricular dimensions and function. Identification of patients with right ventricular dysfunction depends on tricuspid annular plane systolic excursion less than 17 millimeter, tricuspid annular systolic velocity less than 9.5 centimeter per second, right ventricular fractional area less than 35%, and inexperienced labs 3D measurements of right ventricular volumes can be considered, which are very similar to those obtained by cardiac magnetic resonance. The literature history of tricuspid regurgitation. In severe primary tricuspid regurg, there is a poor prognosis, even if it may be well tolerated functionally for years. Flared tricuspid valve is associated with decreased survival and increased risk of heart failure. Pulmonary hypertension, increased right ventricular pressures and dimensions, reduced right ventricular function, AF, pacemaker leads, the severity of tricuspid valve deformation, are all important risk factors for persistent or late worsening of secondary tricuspid regurg. The use of prophylactic tricuspid annuloplasty in the presence of a dilated tricuspid annulus and mild to moderate tricuspid regurg was associated with reduced rate of tricuspid regurg progression and improved right ventricular remodeling and better functional outcomes. Medical therapy of tricuspid regurgitation. Diuretic. Diuretics reduce signs of congestion. Specific therapy are those of the underlying disease. Drugs reducing pulmonary artery pressure or pulmonary vascular resistance or both might be considered in patients with severe functional tricuspid regurg and severe pulmonary hypertension. This slide shows the indication of surgery in tricuspid regurgitation, which depends mainly on the need for left-sided valve surgery, the kind of tricuspid regurg, whether primary or secondary, the severity and the presence or absence of right ventricular or left ventricular dysfunction, and the presence or absence of pulmonary hypertension. Tricuspid stenosis is often combined with tricuspid regurgitation. It is most frequently of rheumatic origin. It is therefore almost always associated with left-sided valve lesion, particularly mitral stenosis, that usually dominate the clinical presentation. Other rare causes: congenital tricuspid stenosis, drug-induced valve disease, Whipple's disease, endocarditis, large right atrial tumor, and carcinoid disease. The pathophysiology of tricuspid stenosis. The normal valve area is around 7 to 8 centimeters. A pressure gradient occurs if it is smaller than 2 centimeters. Tricuspid stenosis usually induces a small, less than 5 millimeter mercury diastolic pressure gradient between the right atrium and the right ventricle that increases during inspiration due to increased venous return. A mean pressure gradient of more than 5 millimeter mercury is indicative of significant tricuspid stenosis and is usually associated with evaluation of tricuspid stenosis from the history. The main symptom and clinical signs are often those of associated valvular lesion. Increased venous pressure results in symptoms of right-sided heart failure, and there may be low cardiac output that causes fatigue. On physical examination, usually there is a diastolic murmur of low intensity, increases with inspiration, and preceded by an opening snap. Pre-systolic together with pre-systolic jugular distension and signs of systemic venous congestion. The ECG usually shows right atrial hypertrophy or more frequently biatrial hypertrophy. AF is present in one half of cases. Chest X-ray usually shows cardiomegaly with right atrial dilatation. Coexistent mitral stenosis results in left atrial enlargement, but the degree of pulmonary congestion is less than usual in the presence of mitral stenosis. Echocardiography provides the most useful information. Tricuspid stenosis is often overlooked and requires careful evaluation. In rheumatic disease, the leaflets are thickened with reduced motion and frequent commissural fusion. The podi are shortened and thickened, and there is usually diastolic doming. In carcinoid syndrome, retraction of the leaflet or subvalvular apparatus or both toward the apex persists during systole. The pressure half-time method is less valid for assessment of severity of tricuspid stenosis than of mitral stenosis. Planimetry of the valve area is usually impossible unless 3D echocardiography is used. No generally accepted grading of tricuspid stenosis severity exists. A mean diastolic gradient of 5 mm mercury or higher at normal heart rate is considered indicative of clinically significant tricuspid stenosis. Catheterization is no longer used for evaluating tricuspid stenosis severity and has been replaced by echocardiography. Medical therapy, diuretics are useful in the presence of heart failure but are of limited efficacy. The lack of pliable leaflet tissue is the main limitation of valve repair. Even though there is still a matter of debate, biological prostheses for valve replacement are usually preferred over mechanical one. Regarding percutaneous intervention, percutaneous balloon tricuspid dilatation has been performed in a limited number of cases, either alone or alongside percutaneous mitral commissurotomy. But this frequently induces significant tricuspid regurgitation. There is lack of data on evaluation of long-term. Intervention on the tricuspid valve is usually carried out at the time of intervention on the other valves in patients who are symptomatic despite medical therapy. The choice between repair or replacement depends on the valve anatomy and on surgical experience. This is the indications for tricuspid valve surgery. Thank you.